I just think that our distinguished participants will see me better. Madam Deputy Minister, Mr. Chairman, ladies and gentlemen, thank you very much for the kind invitation to participate in your conference today and to say a few words on behalf of the World Health Organization. So I'm the representative of the World Health Organization and head of country office in Czech Republic. That would be in Czech, it would be the WHO představitel and ředitel kanceláře. I'm here only for, I have been here only for the past 10 weeks, so this is a great advancement for me in Czech language. Prevention of diseases is the central and the most important component of an effective public health approach to preserving and improving health and well-being. Advances in science and medicine in the 20th century, and particularly in the past 20 or 30 years, provided us with knowledge and tools to significantly reduce the burden of cancers in particular. Yet this did not diminish the importance of prevention, and in particular of primary prevention. Now, cancer is the most important cause of death and morbidity in Europe after cardiovascular diseases. Cancer is in many cases avoidable. Screening and early detection increase the success of cure and survival substantially. While we focus in this conference on screening and to some extent on early diagnosis of cancer, let me emphasize that those interventions, combined with an affordable and effective treatment, do not solve the problem completely, but are significant and essential components of a comprehensive strategy to address cancer in this country. Early diagnosis and screening are both important components of comprehensive cancer control, but are fundamentally different in resource and infrastructure requirements, their impact and their cost. Cancer screening seeks to identify unrecognized and preclinical stage cancers or precancerous lesions in an apparently healthy target population. On the other hand, early diagnosis is defined as the early identification of symptomatic people or cancer in patients who already are at the early stage of disease. Screening uses procedures that can be applied rapidly and accessed widely by the target population. Screening differs from early diagnosis also in that an entire target population is evaluated for unrecognized cancer or precancer, and the majority of individuals tested will not have the disease that we are looking for. So screening should be viewed as a process, not as administering a particular test, examination, or procedure. The screening process includes a system of informing and inviting the target population to the largest extent of this population to participate in screening programs, administering the screening test, following up with test results, and referrals for further testing among those with abnormal test results on screening, and ensuring timely pathological diagnosis, staging of the disease, and access, rapid access, I would add, to effective treatment with routine evaluation to improve the process. So, as Madam Deputy Minister mentioned, screening as part of a very comprehensive response to the cancer problem in every country is part of a very complex public health intervention that needs to be done in full in order to get the biggest benefit out of it. It is very important that an evidence-informed assessment of current capacity and potential harms versus benefits be performed before introducing or scaling up a program for cancer early diagnosis or screening. Screening programs should be undertaken only when their effectiveness has been demonstrated, when resources such as personnel or equipment are sufficient to cover nearly all of the target group, when facilities exist for confirming diagnosis and for treatment and follow-up of those with abnormal results, and when prevalence of the disease is high enough to justify the effort and cost of screening of large populations. And even when implemented properly, screening programs associated with undesirable effects sometimes, which may include, for example, false positive screening tests that result in adding additional testing, invasive diagnostic procedures, and patient anxiety. False negative screening tests that provide false reassurance and can result in delayed presentation or diagnosis when symptoms do appear. Or, for example, overdiagnosis and overtreatment of preclinical cancers that could have never caused symptoms nor pose a serious threat, and which involve unnecessary treatment that injures the patients in the end. Potential benefits of good screening are obvious, on the other hand, and they include a reduction in incidence in target population if precursors are detected and treated by screening. For example, for cervical or colorectal cancers, or reduction in stage of disease at diagnosis, therefore increasing the treatment chances and the chance of survival. And I think that the data that has been gathered so far in this project documents actually that various kinds of interventions in screening and early detection have an impact on how early we diagnose, what are the outcomes, and it also teaches us that there are very different situations with different cancers. So one really has to make a differential diagnosis when we talk about prevention and screening programs for cancer and see what works and what doesn't work, what generates positive effects and what really is associated with certain risks. Current evidence documents well the benefits of screening in high research settings, like Czech Republic, for a limited number of cancers, for example, cervical, breast, and colorectal cancers. But it also documents the risks and significant costs in high-income countries like this. Weighing the harm against the benefits of screening has also led the WHO not to recommend certain procedures for screening, for example, mammography screening for women under the age of 50. Based on the existing evidence, mass population screenings can be advocated only for cervical, breast, and colorectal cancer for wide segments of the population. For example, systematic prostate cancer screening for all men above a certain age using prostate-specific antigen is not recommended by WHO. The high harm-benefit ratio has resulted in the abandonment of population-based PSA screening for prostate cancer in many countries of Western Europe in the past years. Cancer prevention policies and programs should focus on improving early diagnosis before implementing cancer screening on a mass scale whenever possible. WHO supports countries in implementing the 4 basic components of cancer control: prevention, early detection, diagnosis and treatment, and also palliative care to prevent and cure many cancers and to alleviate suffering where we fail. So let me conclude by going back to the primary prevention. Enough is known about the causes that we can address to prevent at least 1/3 of all cancers. Key measures include implementing tobacco control measures, maintaining a healthy body weight, and conducting population-based screening, for example, for cervical cancer. Let me remind you that we also have technologies available today to prevent some cancers very effectively, for example, through vaccinations against the HPV virus, which is the primary cause of cervical cancer. It is a highly contagious infection that is transmitted through sexual or skin-to-skin contact. The HPV vaccine is almost 100% effective in preventing the persistent HPV infections that are the leading cause of cervical cancer. Despite these gains and knowledge, today 1 in 25,000 women die from cervical cancer in the WHO European region. It remains the second most common cancer among women aged 15 to 44. Given the technology and development levels in the region, women have a right to be protected from this disease. Introducing the HPV vaccine more widely in combination with cervical cancer screening has the potential to further lower mortality rates, particularly among younger women. This is just one of the examples where actually we need to look at the whole spectrum of measures in order to address properly the burden of disease from cancers. For other cancers, one could pull other examples or stories, depending on the nature of the disease and on the tools and knowledge that we have today. The subject of today's conference remains an important element of good cancer control in any country. This is an impressive meeting of experts and practitioners in this area, and I'm sure that your deliberations will further improve the outcomes of cancer control programs in the Czech Republic, learning the lessons from practice and looking at the evidence that will inform your future course. In the end, I believe that the cancer control programs in the Czech Republic, which are on the right track, will bring further health benefits to your citizens. I wish you, on behalf of WHO, a very fruitful conference and much success in your continuous work on improving health and well-being of the people in this country. Thank you very much.